We have the fourth and the last presenter of Part 3, the Dr. Theodoros Kelesidis, Associate Professor of Department of International Medicine, Division of Infectious Disease at the University of Texas Southwestern Medical Center. So please welcome him with a big round of applause.
Okay. Thank you. I would like to thank Rydell for the opportunity to talk about this important topic regarding HIV, cardiometabolic disease, and the role of HDL in people with HIV. Oops. These are my disclosures. So people with chronic HIV infection have multiple comorbidities. They have increased risk for cardiovascular disease, for cancer, bone disease, diabetes, cardiometabolic syndrome, liver disease, fatty liver disease, kidney disease, and also neurocognitive problems. Today we're going to focus on atherosclerotic cardiovascular disease. The burden of cardiovascular disease in people with HIV is quite high, as you can see in this map. In red, you can see the number of people with atherosclerotic cardiovascular disease in the world. You can see a high prevalence in multiple countries, especially in Africa, where there's a high burden of HIV, but also in the United States and all over the world. And it's not just the numbers, but you see on the bottom map is the morbidity associated with cardiovascular disease with people with HIV. So they have at least twofold higher risk for heart attack and stroke compared to uninfected controls. And there's accelerated aging, so people get heart attacks and strokes much sooner compared to controls without HIV. And this is a quite complex disease, so there are multiple effects of aging, genetics, obesity, exercise, diet, smoking, and also the virus per se. There is toxicity of the antiretroviral medications. There are also other co-infections like hepatitis C, the traditional cardiometabolic risk factors, right? Abnormal lipids, insulin resistance, inflammation, and fibrosis. They all collectively drive end-organ disease, as you can see here. The pathogenesis is quite complicated. There's a complicated crosstalk between multiple factors. The virus, the viral proteins, they have their independent effect. There's also a combined effect of the antiretroviral itself. This modify the lipids and lipoproteins together with the traditional cardiometabolic risk factors contribute to a complicated crosstalk between the platelets, the endothelium, and the immune system. Collectively, this drives the atherosclerotic cardiovascular disease. Specifically, there's a phenomenon called immune activation in chronic HIV infection. This means that the immune system, like macrophages, they are more active. So basically, the virus itself and the viral proteins, they have a major role in that. There are also the co-infections like CMV. There's abnormal gut, we call it the leaky gut. So the virus attacks the gut, and it's basically there's leakage from bacteria into the blood, like endotoxin. This drives inflammation, and this has a major role for HDL function, as we're going to talk about this later. This collectively drives a pro-inflammatory environment and also modifies, changes the lipoproteins, like HDL. Specifically, what does the virus do with the lipids? It can change the lipid clearance. It can affect the liver for the hepatic synthesis of VLDL. It reduces HDL levels and increases triglycerides. And this is just the virus. Also, it can impair reverse cholesterol transport through multiple effects. As you can see, multiple enzymes are affected, like the CTP, the LCAT, the triglyceride contents. So the HIV can directly impact the metabolism of HDL. This is quite known. And this is just the effect of the virus itself when people have viremia for a long time, which is not the case these days because we have potent antiretroviral therapy. This used to be more relevant many years ago when we didn't have effective treatments to control the virus. What happens now is what happens with the antiretroviral therapy, which is also very important. Like certain proteins like NEF, they have their independent proatherogenic effect. But what happens these days when people take their pills, there's no viremia, there's no virus in the blood, right? So then what really drives this inflammation when the virus is gone? It has been shown that actually antiretrovirals, they have their own independent effect. They affect the oxidative stress, they increase oxidative stress. They have actually pro-inflammatory effect, some of them. They mess up the mitochondria. And some of them, these are some of the classes, which I'm not going to go over specifics detail, they have the independent effect on the inflammation and the lipids. They can increase the oxidation of the lipids, and then it can impair the accumulation of cholesterol. So the drugs may not be as innocent as we thought they are. They are great because they suppress the virus, but they have their own problems. This is a slide summarizing the many roles of HDL has in human disease and infection, specifically before we go over HIV. So the virus changes lipids, and what HDL does, it improves reverse cholesterol transport. The virus causes endothelial dysfunction, so the HDL also improves endothelial repair. The virus compromises the immune function, and what HDL does, it has favorable anti-inflammatory and immunomodulation effects. The virus increases the oxidative stress, and what does HDL do? It has an antioxidant effect. So as you can see here in this slide, there are multiple favorable effects that HDL has in chronic HIV infection. It's a very, very pleiotropic protective function in multiple infections, it's specifically HIV infection. It also has antithrombotic effect. The virus also increases coagulation, which increases the incidence of stroke and heart attack. There's also an adiapoptotic effect, which is also high relevant for chronic HIV infection. Also, one part that is less known for HDL, that it's part of the innate immunity, actually. So it can bind endotoxin and microbial products that bacteria make, and also it can neutralize viruses directly. It can have a antiviral effect. This has been shown for SARS-CoV-2, influenza, and some other viruses as well. And also, what's very important to note is that it interacts with most of the cells of the immune system. As you can see here, it interacts with the lymphocytes, with the macrophages, with the dendritic cells, so many functions. So it's a really key important part of the innate immunity that is often under-recognized. But what happens during systemic inflammation, like atherogenesis, is that the HDL loses its protective function, it changes structure and function. So on the left in blue, you see the healthy HDL with the blue protective enzymes like ApoA1, the main protective protein, but then during systemic inflammation, you see in red, there are some pro-inflammatory proteins that they come in, they take over, and the structure, the function of HDL changes, and that collectively can drive immune activation and inflammation and cardiovascular disease. So specifically with HIV, it has been shown that there are altered HDL particle subclasses, as was mentioned earlier. This is quite important for the ability of HDL to function. And this has been shown in multiple different papers. So basically, there are different sizes of the HDL particles. They are larger and they are less stable. And they bind to receptors in a different way. Also, the cholesterol efflux is reduced in chronic HIV infection. There is a reduced content of certain HDL proteins that have protective role, like paraoxonase that has antioxidant effect. Also, there is less anti-inflammatory activities with HDL. We saw that many years ago. That HIV HDL has reduced anti-inflammatory activity using a cell-based assay of endothelial cells from the aorta. Then what we were interested is we develop a high-throughput assay to study this on a larger scale because cell-based assays are difficult to do on a large scale. So using a biochemical assay that we measure the